Hi, welcome to the University of Florida College of Veterinary Medicine. My name is Dr. Jim Sampson. I'm the professor of small animal internal medicine, and I'm board certified in internal medicine, oncology, and immunology. And I'm here to talk to you today about immunology as you work to prepare to study for your North American veterinary licensing exam. The first slide that I'd like to show you here is kind of a brief overview of what we expect the immune system to do, which is to protect the body against invasion by either microorganisms or chemical agents. There are some key cells that you need to be aware of within the immune system. These are the lymphocytes, which are responsible for producing antibodies known as the humoral immune response, and also T lymphocytes, which are responsible for development of the cell-mediated immune response. Likewise, there are some key inflammatory cells that you need to be aware of. These are macrophages, neutrophils, and mast cells. And as we work through these diseases that affect animals in veterinary medicine, I'm hopeful that these responses and cells involved will become more apparent to you. Another component of the immune system that you need to be aware of is complement. It's a series of proteins. Complement is a non-specific part of the immune system, and you can activate it by one of two mechanisms, either the classical pathway activation, which involves antibodies and antigens forming a complex, or the alternative pathway, which involves the organisms only and complement recognizing the organisms as being foreign. There are three proteins within the complement cascade that I particularly want you to be knowledgeable of. These are C3b, which is the third component of complement. C3 is split to form C3a and C3b. Both of these are extremely prevalent within mechanisms of immune responses. C3b binds to the surface of microorganisms or cells and allows those organisms or cells to be identified as foreign, and allows macrophages and neutrophils to then bind to the organisms and engulf them or phagocytize them. C3a is called a chemotactic factor or an aflatoxic factor, and is responsible for enhancing the inflammation as the disease processes progress. C5a is also chemotactic and aflatoxic, resulting in increased inflammation. And I'm going to give you some specific examples as we work through where C3a and C5a play a role. And the important thing is you know that those three are key. The antibody molecules that I want you to be aware of, there are 5. IgM, IgA, IgD, IgG, and IgE. Those are the only 5 antibody molecules known in veterinary medicine, and they make up the little acronym MADGE, M-A-D-G-E. It's sort of an easy way to remember these molecules, and I would expect you to be able to know all 5 and what roles they play. The largest molecule is IgM, and it is a pentameric molecule, meaning it has 5 subgroups associated with it. It is the largest by far of all the molecules, and we're going to work through that in just a moment. The last thing that I want to go through with this PowerPoint before I switch to the slides is a phenomenon known as hypersensitivities, and these are the diseases that we're going to be talking about as we work through our seminar today. Type 1 hypersensitivities are caused by IgE, and it's known as an anaphylactic immune response. This can be observed following routine vaccinations in any animal and following the transfusion of blood into any animal. Likewise, insect stings, exposure to chemicals can also cause anaphylactic responses. Type 2 hypersensitivities are known as the cytotoxic immune responses. These are common in what's known as IMHA, or immune-mediated hemolytic anemia, IMT, known as immune-mediated thrombocytopenia, and Evans syndrome, which is a combination of both immune-mediated hemolytic anemia and immune-mediated thrombocytopenia in animals. The type 3 hypersensitivity is known as immune complex disease, and the characteristic disease that we recognize in animals with type 3 hypersensitivity is known as systemic lupus erythematosus, or SLE. And the last is a type 4 hypersensitivity, which is not mediated by antibodies. Types 1, 2, and 3 are all antibody-mediated. Type 4 is a cell-mediated immune response, and it's known as a delayed type hypersensitivity. And an example of that would be contact dermatitis or flea bite dermatitis. All right, if we could switch now to the slides. When you work through immune responses, there are 4 phases that occur with all immune responses. The first phase is recognition of the antigen or the foreign substance being introduced into the body. This could be a chemical or a bacteria or a virus or a fungal or a parasite. Whatever foreign material is introduced, the first phase is recognition. The second phase then is a proliferation of the immune response. The third phase is the destruction of the invading organism. And the last phase is the resolution or taming down of the immune response. This is an example of a normal antibody molecule. It's composed of several regions that I want you to be able to recognize. On the left-hand side of the screen, there are 2 sites called the antigen binding sites. And those are the areas where the antibody molecule actually attaches to the invading particle. And again, it could be a chemical or a virus or a bacteria or a fungal agent or a parasite, whatever. If you'll notice on the molecule, the left-hand side, those 2 ends, that's known as the FAB region of the molecule, and that stands for the fragment which binds antigen, or fragment antigen binding, FAB. You'll notice that there are 2 sites where antigen could be bound, and so there are 2 FAB sites. On the far right-hand side of the molecule, that section of the molecule is known as the FC region, and it stands for the fragment which binds complement. And remember, we talked about complement being a series of proteins of which you generate C3b, C5a, and C3a. The yellow part of the molecule on the screen are the 2 heavy chains, and so there are 2 heavy chains associated with each antibody molecule. And on the outer sides, the light white area that's cross-hatched and the very light yellow are the light chains. So there are 2 light chains and 2 heavy chains which make up an antibody molecule. The light chain weighs about 25,000 Daltons, and so it's a relatively small protein. To give you a comparison, albumin in the body, which is the most prevalent protein in the bloodstream, albumin weighs 67,000 Daltons. So a light chain is very small at only 25,000. The heavy chains, as you can see in this diagram, are about twice as big as the light chains. And the heavy chain's molecular weight is 50,000 Daltons. So if you add together the 2 heavy chains and the 2 light chains, 50,000 plus 50,000 plus 25,000 and 25,000, the molecular weight of a normal antibody molecule is about 150,000 Daltons. That becomes important because as we get later in the seminar, we'll talk about some diseases caused by light chains, and it's important that you know that they're very small, at only 25,000 molecular weight. An IgM molecule, as I said before, is pentameric, which means it is composed of 5 antibody molecules tied together. And so the molecular weight of IgM would be 5 times 150,000. And so you can see that it is huge. IgM hardly ever gets out of the bloodstream because it is so big, versus IgG And IgD and IgE can migrate out of the intravascular space into the interstitial space fairly frequently because it's a little smaller. So, but IgM is strictly known as an intravascular antibody. It is so big that it never gets out of the bloodstream. Okay, this next diagram shows three fingers holding an apple. And this is a representation of what the FAB, or the fragment antigen binding, how it would bind an antigen within its space. I'm going to back up one slide just for a second. If you notice on the left-hand side, those areas, those two areas, the antigen binding sites, is where antigen would bind. And that part of the molecule is very hypervariable. And depending upon what amino acid sequence makes up your heavy chain and light chain will depend upon what kind of antigen you're able to bind. In this case, you can see that this apple fits very nicely in this representation of a antigen binding site. And an apple may fit there, but a basketball would not. And so depending upon what antigen you would have, will depend upon what kind of antibody molecule it's able to bind to. Now this representation on the left-hand side there of the far slide, again, is another antibody molecule. And if you look closely, you can still see the representation of the two heavy chains, which have a component stuck in the cell membrane there, and two light chains, which are now on the interior aspect of the antibody molecule. This is to give you a representation that many things in immunology look the same. In the very middle drawing, that is the T cell receptor for antigen, and you can see that it too looks like part of a light chain and part of a heavy chain stuck into a membrane. And its site that binds antigen would be very similar to how an antibody would bind antigen. The two molecules on the far right are class 1 major histocompatibility receptor site and a class 2 major histocompatibility receptor site. And again, you can see how they look very similar to an antibody molecule where you have chains that look like a heavy chain and a light chain. This is a representation of a T cell receptor. It would be on the present surface of a lymphocyte known as a T cell, and it's responsible then for binding antigen between its two chains. You can see that there is an alpha chain on the left and a beta chain on the right, and a portion of the molecule is embedded within the cell membrane with two tails sticking down into the cytoplasm of the cell. And this antigen, or this receptor, would be responsible for binding antigen and stimulating that T cell to respond to the foreign molecule. Antigen recognition then by B cells and T cells is a little bit different. Now, B cells are responsible for making antibody molecules, and that's the humoral immune response. T cells are responsible for initiating the cell-mediated immune response. B cells on the left-hand side of this slide are capable of recognizing all different types of molecules: proteins, nucleic acids, polysaccharides, and lipids. Whereas T cells, and the ability of them to recognize antigens, is limited to proteins only. They can only recognize foreign proteins. It's impossible for them to recognize carbohydrates or polysaccharides or lipids. And the reason for this is that T cells must recognize their antigen in association with a cell called the antigen-presenting cell. And those are macrophages, other B lymphocytes, dendritic cells or Langerhans cells, which are also macrophage-like cells. The T lymphocytes can be broken up into two groups. On the left-hand side of this slide, I have listed what's called a CD4 positive T lymphocyte. CD stands for common determinant 4, and these are known as the T helper cells. T helper cells again, recognize proteins only, but these proteins are bound to class 2 major histocompatibility molecules. And this is important. Only class 2 MHC molecules can present proteins to T helper cells for them to amplify and respond as part of the cell-mediated response. And in most cases, these proteins come from extracellular bacteria or soluble protein antigens that have found their way into the body. Now, CD8 T lymphocytes, which is located on the right-hand side of this screen, are known as cytotoxic lymphocytes. These are able to recognize, again, proteins only, but these proteins are bound to class 1 MHC molecules. And that's a major difference in this immune response. T helper cells respond to proteins attached to MHC2 molecules, whereas cytotoxic T cells bind to proteins bound to class 1 MHC receptors. And this is an example now of a class 2 molecule being used to show protein to a T helper cell. So on your left-hand side, you can see that there are 2 antibody molecules there represented by the AB, and they have bound to antigen recognized by the AG, and they are being held on to the macrophage by the FC receptor. Remember, FC stands for the fragment which binds complement. And macrophages and neutrophils all have receptors for FC components of the antibody molecule, and this aids in what's called phagocytosis. So that antigen in the bloodstream was bound by those 2 antibody molecules. Those antibody molecules are then recognized by the macrophage, which is abbreviated in the center M-phi, which is that vertical slash mark through the 0. And the antigen is brought into the cell. It's fused in with a phagosome to destroy the antigen. The antigen then moves to the right and is bound to a class 2 molecule, and the protein, the little diamond-shaped or home plate-shaped blue marker is able then to be presented to the T helper cell, or the TH cell on the right-hand side. So the important thing for you to know here is that class 2 molecules present protein to T helper cells. I'm going to skip through this slide because it is too small for you to read, but it works through the mechanism of how antigen is presented to T helper cells, and it's summarized on the following slide. And this is the summary, and I'm going to make sure that we work through this. Okay, principal steps in MHC-associated antigen presentation. This is class 2 molecules. Okay, the first step is you have to internalize an extracellular protein antigen into the antigen-presenting cell, the APC. In this case, it was a macrophage. The antigen is then processed inside some acidic endosomes, leading to peptide fragments, or small protein segments. Those protein segments are then bound by low affinity to a class 2 MHC molecule. The class 2 MHC molecule and peptide complexes are then expressed on the surface of the antigen-presenting cell, and then those complexes are recognized by T helper cells specific for that foreign peptide and the self-MHC molecule. Now, I know that's a lot to bite off, okay, but you can work through this. You need to know that class 2 MHC molecules are able to show protein antigens to T helper cells. That's an important concept that I need you to know. It may come up on your national licensing board. This next molecule that you can see is a class 1 molecule. It's similar to the class 2. It has one protein, the yellow protein, which surfaces into the cytoplasmic membrane. And so it's only got one protein that goes into the plasma membrane versus the class 2 molecule had 2. And it's got a small gray single peptide to the right, which is called the beta peptide, and it is on the surface only. It does not extend into the cell membrane. Its function is the same, though. This class 1 molecule is going to bind protein and present it now to a cytotoxic T cell so that the cytotoxic T cell can recognize this cell as being infected. And again, this is a detailed flow chart of that process, of which I'm going to walk you through a step by time on this next summary slide. So the principal steps in MHC-associated antigen presentation for class 1, and these class 1 molecules are usually associated with viral infections or tumor cells. So in this case, we're going to work with a virus. A cell is infected with a virus. Let's say it's a cell in the back of an animal's throat. That viral protein gets inside the cell as the virus replicates, and the protein is then expressed inside the cell cytoplasm. The second step then is that viral protein is processed with rough endoplasmic reticulum, and the new protein then is expressed in combination with a class 1 MHC molecule. The viral peptide class 1 MHC molecule is then transported to the surface of the cell through a Golgi apparatus and an exocytic vesicle. The two fuse on the surface of the cell, and now you have a class 1 MHC molecule with a foreign protein from that virus attached to it. That complex has been shown to what's called a T cytotoxic cell, and this cytotoxic cell is able to destroy that infected cell. And so in this case, the cytotoxic T lymphocyte nestles up next to the infected epithelial cell in the back of the throat, and it actually destroys that epithelial cell so that the virus is not able to escape. And this is known as cytotoxic T cell destruction. And we see that in some tumors that express antigens, and you have an immune response to the tumor and actually destroy the tumor, and we see it with viral infected cells. All right, what I hope to do now is to work you through some immune-mediated hematological diseases and then try to begin to tie together some of these immunological concepts with some actual diseases. So the first thing we're going to talk about is an overview then of some hematological diseases that are caused by an overactive immune system. And in this case, you could have hemolytic anemia, commonly known as immune-mediated hemolytic anemia, or IMHA, or it's also known as autoimmune hemolytic anemia, or AIHA. You can have immune-mediated thrombocytopenia. You could have Evans syndrome, which is a combination of both immune-mediated hemolytic anemia and immune-mediated thrombocytopenia occurring at the same time. You could have autoimmune neutropenia, where you have an absence or very low circulating neutrophil numbers in the peripheral blood. Systemic lupus erythematosus, pure red cell aplasia, or isoimmune hematological disease of neonates. The actual prevalence of immune-mediated hemolytic anemia is really unknown. We do see it, though, as a frequent disease in dogs. In dogs, immune-mediated hemolytic anemia has been associated with vaccine administration, modified live vaccines. And of the two, both immune-mediated hemolytic anemia and immune-mediated thrombocytopenia are most common. In cats, most of the occurrences are single case reports, except for a report of thiouresil-induced immune-mediated hemolytic anemia in cats that were treated for hyperthyroidism. So you should be aware that thiouresil, or propylthiouracil, has been associated with immune-mediated hemolytic anemia in cats. This type of disease process is known as a type 2 hypersensitivity, and we talked about that earlier. In a type 2 hypersensitivity, antibodies bind to the surface of cells. And so all type 2 hypersensitivities are associated with antibody molecules binding to the surface of cells. And in this case, I've pictured here an IgM molecule, which again is pentameric, and you can see that there are 5 antibodies all tied together with IgM. And I have 2 IgG molecules there side by side. Both of those molecules then are able to bind to the surface of that red sphere, which in this case represents a red blood cell. Once those antibodies are on the surface of that cell, you activate the complement system, and you cause the formation of some complement split products, of which C3b, here located as the red squares, bind to the surface of that red blood cell and have changed now to blue squares. And all of this leads to either one of 2 phenomena. Either the red blood cell will lyse, causing intravascular hemolysis, or the red blood cells can be agglutinated and then phagocytized by circulating macrophages or neutrophils. And in each instance, then, you get a reduction in the number of cells that were in the peripheral blood. If the antibodies are targeted against blood cells, you get immune-mediated hemolytic anemia. If the antibodies are targeted against platelets, you'll get immune-mediated thrombocytopenia. If the antibodies are against neutrophils, you would get immune-mediated neutropenia. Okay, so this is Annie. Annie is a 6-year-old female spayed poodle mix. Her primary complaints were decreased appetite, weakness, and lethargy for 3 days' duration. This is a picture of Annie. You can see she's a poodle mix. Kind of looks like a Cocker Spaniel to me, but the owners assured me that she was a poodle mix. On physical examination, Annie was quiet and was well hydrated. Her mucous membranes were pink. Her capillary view field time was 1 second, and her rectal temperature was 102 degrees Fahrenheit. On her eyes, ears, nose, and throat, there were no significant findings. Heart and lungs, her heart rate was 180, normal sinus rhythm, very rapid. There was a 2 out of 6 holosystolic murmur. Her pulses were fair. She was tachypnic. She was breathing at 44 breaths per minute, but her lungs were clear. On abdominal palpation, you could feel that there was something big in her cranial abdomen, but I couldn't tell whether it was her liver or her spleen. Her musculoskeletal system was no significant findings. Her urogenital, she was a female spayed. She had no mammary gland tumors and no vaginal discharge. Her integument was good, and her peripheral lymph nodes were within normal limits. So I tried to work through this slide relatively slowly so you could begin to pick up some of these abbreviations. And I'm hopeful if you need to go back and listen to it on the tape, you can. But we're going to be using this format repeatedly on cases as we work through these diseases. This is Annie's X-ray. And on the left-hand side of the screen at the top, you can see a little bit of her lung fields. And on the left-hand side of the screen on the bottom, you can see that her abdomen is very full with a very whitish, radiodense structure. And based upon this radiographic analysis, she's got evidence of an enlarged liver. No other abnormalities are noted in her abdominal cavity except she's a little bit on the fat side. This is her biochemistry profile. Her alkaline phosphatase is a little bit elevated at 698. Her ALT and AST are both elevated. Her electrolytes are pretty much within the normal limits. Her calcium is a little bit on the low side at 8.6. But if you look over at her albumin, which is directly across from the calcium, her albumin is a little low too at 2.5. And if you correct the calcium level for the level of albumin, the calcium becomes within the normal limits. The creatinine on the top right is normal at 0.9, and the BUN is normal at 22. Her glucose is okay. Her total CO2 is normal. Her bilirubin level, though, is elevated. So she's got increased bilirubin, which could go along with her slightly enlarged liver. So at least we have an indication that there might be something going on in her liver. On her hemogram, her hematocrit is low. It's 16.8%. And her mean cell volume is very high at 87 femtoliters. This is much higher than it normally is. Normal mean cell volume for a dog is roughly 60 to 77. Her MCHC is normal. Her white blood cell count is markedly elevated at 46,400. This is very high. And if you look at the breakup of her white cells, her neutrophils are 34,800, and she has a left shift of band neutrophils near 8,000 and metamyelocytes even near 1,000. Her lymphocyte count is normal. Her platelet count is just fine at 360,000. Her fibrinogen is a little bit elevated, and her total proteins are within the normal limit at 6.2. You can see her Richter's index is high, though, at 15 to 20, and she's got nucleated red blood cells in her peripheral blood. So this hemogram shows evidence of low red cell counts, a high white cell count with a left shift, an elevated icterus, and nucleated red cells. And this should alert you to the fact that she might be having a regenerative red blood cell response. The fact that she's got nucleated reds, the fact that the mean cell volume of the red cells is elevated at 87 femtoliters indicate or suggest that she would have a regenerative anemia. Now, the only way to prove that would be to run a reticulocyte count, and so that would be one of your next steps as you work through this problem. Now, this is the blood smear from Annie, and on the top left-hand side, you can see a really dark-looking red blood cell. It's much smaller and much more dark than another red cell just to its right. And the little tiny red blood cell up there, actually I can see on this slide 1, 2, 3, 4 very tiny dark red cells. These are known as spherocytes. They're very spherical and very round, and they've lost their central pallor. Most of these other red cells that you can see on the screen have some evidence of pallor or whiteness in the middle of them. These small, dark, rounded up red blood cells are a hallmark sign of immune-mediated hemolytic anemia, and they're known as spherocytes. What has happened is the antibody molecule has bound to the surface of that red blood cell, and the red blood cell has then been taken up by an inflammatory cell on the right-hand side of this screen known as a macrophage, and it has chewed off a little bit of the surface of the red cell, making it smaller, and then it spit it back out, and it went back into the circulation as a small, rounded-up red cell. And so when you see evidence of spherocytes on your peripheral blood smear, you should immediately think of immune-mediated hemolytic anemia. This is another blood smear from an animal actually showing you a macrophage that has ingested 3 red blood cells. And if you look around this smear, you can also see other evidence of small spherocytes. So this would be indicative of an underlying antibody-mediated immune response to red blood cells. And immune-mediated hemolytic anemia would be on the top of your differential diagnosis list. All right, now this is a reticulocyte stain of a peripheral blood, and what you're doing here is trying to document that indeed this animal has a regenerative red blood cell response. And the stain here is called a new methylene blue stain, and the dark blue spots that you can see in those red blood cells are aggregates of proteins. And you might ask yourself, well, what protein would immature red blood cells have that would be staining this color? And the protein that these immature red blood cells have is hemoglobin. They're very young. They have not made all the hemoglobin that they need yet because they're still in the process of maturing and becoming a normal red blood cell. And so not until all the protein is transcribed off of ribosomes and is made and is packaged as hemoglobin, do you lose those aggregated protein or ribonucleic acid molecules. And so this is a reticulocyte stain. This is indicative of an immune or a regenerative red blood cell response. So we did a count on Annie, and Annie had 27% reticulocytes, which is very high. And we also did a Coombs test on Annie's red blood cells, and she was Coombs positive for both the presence of IgM on the surface of her red cells and C3b on the surface of her red cells. So the signalment for immune-mediated hemolytic anemia and thrombocytopenia in dogs is usually it's a female dog. They're middle-aged, Cocker Spaniels, Old English Sheepdogs, Poodles, Dachshunds, and Irish Setters are overrepresented. There could be a history of vaccination with a modified live virus within the past month, and normally we see an increased incidence of this disease in the spring of the year and in the fall of the year. The clinical presentation of patients are that they're usually weak and lethargic because they're anemic. They usually don't want to eat. They're anorectic. They can collapse if their anemia is severe. The mucous membranes are usually pale. Icterus is normally present, and Annie, remember, she had some elevated icterus on her blood smear evaluation, and her bilirubin level on her chemistry profile was elevated. That's all due to an increased destruction of red blood cells. The reason why her liver was enlarged is because the liver serves as a filter spot for red blood cells that are coated with IgM. So hepatomegaly with immune-mediated hemolytic anemia caused by IgM is common. If the red blood cells were coated with IgG, then usually it's splenomegaly that occurs, and you would pick that up on your radiograph, abdominal palpation, or an ultrasound. All right, next slide. Important historical information then for this disease is the vaccination history. You also need to eliminate other causes of hemolytic anemia, which could include the ingestion of onions. Onions that are either fresh, dried, or cooked in dogs can cause hemolytic anemia. Also, pennies. Pennies that have the interior that are made of zinc can cause hemolytic anemia. You'd want to rule out a recent travel history to areas that were endemic for Babesia or Ehrlichiosis infections. You want to rule out a drug history. Some antibiotics, particularly the penicillins and cephalosporins, can cause immune-mediated hemolytic anemia by those two drugs acting as the antigen being bound to the surface of red blood cells. And lastly, you want to rule out exercise-induced hemolytic anemia due to enzyme deficiencies of red cells. The clinical findings then are depression and lethargy, pale membranes, icterus, bilirubinuria or hemoglobinuria, tachycardia because of the anemia, low-grade murmur because of decreased viscosity of the blood, splenomegaly, and hepatomegaly. Your diagnostic workup, you should do a hemogram, and again what you're looking for here is the presence of possible spherocytes, and you want to do a reticulocyte count to see if it's a regenerative anemia. A serum chemistry profile, looking for evidence of elevation of bilirubin. Urinalysis, looking for bilirubin in the urine. Thoracic radiographs or abdominal radiographs. Autoagglutination test, a Coombs test, an anti-nuclear antibody test, bone marrow, coagulation profile, or specific antibody titers for Babesia or for Ehrlichia as indicated based on your history. The laboratory findings then, usually it's an anemia. It's classified as macrocytic and potentially hypochromic. Elevated reticulocyte counts, nucleated reds, and spherocytes. The white blood cell count is usually high. And remember, Annie had a really high white blood cell count. And if you recall, she had a left shift back to metamyelocytes. And you will learn that left shifts with increased numbers of metamyelocytes or band neutrophils can be associated with infection. But you cannot forget that any time you have a bone marrow that's stimulated, you can have a release of band neutrophils and metamyelocytes as the bone marrow is trying to increase cell production. And in this case, her anemia was so low, at 16%, that the bone marrow was trying to make as many red blood cells as it possibly could. And as it's trying to make more red blood cells, it also ends up making more white blood cells. And as a result, both white cell count tends to go up as well as the release of those reticulocytes. So anytime you have a really strong regenerative anemia, as evidenced by a high reticulocyte count, don't be fooled when your white blood cell count is up high as well. In infections where you have a lot of white blood cells that are out there trying to destroy bacteria that are invading, what will happen is you won't have a regenerative anemia. The reticulocyte count would be low because of the infection. And so you'd have a lot of white blood cells but not a reticulocyte elevation. So anytime you've got a lot of reticulocytes, don't be fooled when your white blood cells are also elevated, because they're just coming along for the ride due to the fact that the bone marrow is so stimulated to produce white cells. Okay. This is a retrospective study that was done on animals affected with immune-mediated hemolytic anemia. Their average age was about 6 years of age, plus or minus 3 years. Collies, Cocker Spaniels, English Springer Spaniels were overrepresented. The most common clinical signs were anorexia at 90%, lethargy at some 86%, white membranes at some 70%, weakness, and icterus. Splenomegaly and hepatomegaly was present in roughly a quarter of the animals. There was severe anemia in many cases with the PCV down around 15%, moderate to severe reticulocytosis. There was mild to severe thrombocytopenia in some cases as well. And there's a reference down there by Alan Clagg in the Journal of the American Veterinary Medical Association back in 1993, volume 202. Spirocytes were present in 67%, autoagglutination in 10% of the patients, a positive Coombs test in 74%, bilirubin was present in all of the animals, hemoglobinuria and hemoglobinemia was present in the animals as well, and some 11% had immune-mediated thrombocytopenia concurrently. Okay, I think I've kind of beat this to death here. Spirocytes, autoagglutination, macroscopic evidence of agglutination, erythrophagocytosis in the blood of the bone marrow of the spleen, a positive Coombs test, and the red cells are very fragile. I need to tell you how to do this saline autoagglutination test. It's done at room temperature, and you take 1 drop of saline, and you can get that out of any bag of normal saline or lactated ringers. Mix it with 1 drop of blood, and then you look for agglutination either with your naked eye or under the microscope. And this is what it will look like on a microscopic slide. So all I've done here is I've taken 1 drop of the patient's blood, mixed it with 1 drop of saline, stirred it around with a toothpick, and then looked for evidence of agglutination or binding of the red cells. And if you put it under the microscope, you'll see the red cells all bound together in these tight balls of red blood cells. Now, it may not be quite this dramatic. If you run into a patient that shows only this level of agglutination, that is still very, very positive. There you've probably got 15 to 20 cells all bound together by antibodies. And these antibodies are just holding the cells right together as a group. Now that's different than this slide. This shows red blood cells kind of stacking on top of each other, much like pennies may stack on top of each other if you were to put them on a table. This is called rouleau formation, and it is not evidence of agglutination. This is a normal phenomenon of blood where the red cells like to stack together on top of one another.
I would hope that you could tell the difference between this, which is agglutination, where they're not stacked but they're bound together, versus this, where the red blood cells are kind of lining up in a line on top of one another. Okay, the Coombs test, this is the diagnostic test when you don't have evidence of agglutination on a slide. You did that, but you didn't see agglutination. Now you would want to send a blood sample to the laboratory and ask them to answer the question, are there antibody molecules on the surface of this patient's red blood cells? And so you draw your blood into a purple top tube, send it to the laboratory, and the laboratory would analyze it. If it's got antibody on the surface, it'll come back as a Coombs positive test, and that would be diagnostic for immune-mediated hemolytic anemia. On this slide, you should recognize that there are some causes of false results. If you don't have a whole bunch of antibody on the surface of the cell, you may not be able to detect a positive Coombs test, even though the animal will still have the disease. Likewise, if your antisera in the lab is too strong, or they wash the cells too much, or the temperature isn't quite right, you can get a false negative result as well. There are some naturally occurring agglutinins that can give you a false positive result, and so in any case, you have to interpret the patient in the light of all the clinical signs and findings that you are observing. But a Coombs test would be the test of choice to diagnose immune-mediated hemolytic anemia when you don't have evidence of direct agglutination. Okay, we're going to skip past that. Complications then associated with immune-mediated hemolytic anemia are collapse and shock. You can also have respiratory distress. Very frequently, animals will develop pulmonary thromboembolisms associated with immune-mediated hemolytic anemia. And you have to watch for other evidence of hemorrhage. You have to rule out concurrent underlying immune-mediated thrombocytopenia or disseminated intravascular coagulation. The treatment aims are to reduce FC receptors. And the FC receptors, remember, were on the presence of neutrophils, monocytes, and macrophages. And that's the receptor that binds to the tail end of the antibody molecule and actually allows the antibody in the red cell to be pulled inside of the macrophage or neutrophil. And so part of your goal is to decrease the numbers of receptors on macrophages, and that makes them kind of blind. They can't see the antibody-coated cells anymore. The other thing that you try to do is to decrease the formation of red blood cell antibodies. You do this with basically two drugs. Corticosteroids at a dose of 1 to 2 milligrams per kilogram twice a day, gradually tapered over the course of 2 months, and that will reduce FC receptors and antibody molecules. Cyclophosphamide will also reduce antibody production, and it's given at a dose of 2 milligrams per kilogram, 4 days of each week. Azathioprine could be used, danazol could be used. There are multiple other drugs that you could be used that are kind of beyond the scope of this particular lecture at this time, but the important things that you need to know is that you're decreasing FC receptor number and you're trying to decrease the numbers of antibodies being formed against these red blood cells. Monitoring, you want to watch the patient's signs, the respiratory rate, the pulse rates, the appetite, and you also want to follow then hepatic enzymes and levels of serum bilirubin. The plan then would be to evaluate a chemistry profile, urinalysis, and reticulocyte counts roughly once a week on these patients. Prognostic features, if the bilirubin is greater than 10, that's not a very good sign. The mortality is usually very high if you have very elevated levels of serum bilirubin. Dogs that have good reticulocyte counts are usually a much better prognosis than dogs who do not have very good reticulocyte responses. So icterus, if you see icterus in a patient, that's usually not a good sign because that indicates that their bilirubin is pretty high. You have to have a bilirubin level of 3 in order for you to see icterus in the skin at this level. And remember, once you get above 10, then the outlook is not very strong. This is an example of urine that was taken from a dog, and you can see in the syringe that it's very dark red, and then the hematocrit tube on the far right side is spun down to show that it's just filled with hemoglobin. And so this animal is exhibiting not only intravascular lysis, but also hemoglobinuria as well. When you put a catheter in, I always get worried because you increase the risk of developing thromboembolic disease, and pulmonary thrombosis associated with catheters has been described in the literature. Cytoxin is a good drug to use in treating this disease. It can be given as a pill form or as a injection form. The purpose of Cytoxin is to prevent antibodies from being formed against the red blood cells. It's not without side effects, though. This particular animal is straining associated with giving Cytoxan therapy to it. And as a matter of fact, it strained so hard that it ended up passing this out of its bladder onto the grass. And if you look closely, you can see that it's not very big. That represents a portion of this animal's mucosa of its bladder. Cytoxin is known to cause a sterile hemorrhagic cystitis, and that's something that I would want you to be aware of as a potential complication of Cytoxan therapy in animals, is the fact that you can get hemorrhagic sterile cystitis. And it is due to a chemical reaction of the Cytoxan with the bladder epithelium. It will occur as you get more and more doses on board. It's definitely something that you need to be aware of as a veterinarian. I would find it very reasonable to have that question asked on a national board examination, is which of the following drugs is associated with hemorrhagic sterile cystitis in the dog, and have a list of some drugs of which Cytoxan or cyclophosphamide would be one of the drugs listed. Educating your clients, 30% of these animals die or are euthanized within the first 1 to 2 weeks. So no matter how good you are as a veterinarian, roughly 30% of these animals will die despite your best efforts. Another 40 to 50% will end up dying or being euthanized in the long term over the period of the next year. The rest of the animals end up going into remission and surviving. Okay, and one more quick case here. This is Wesley, a 3-year-old male castrated domestic white cat. Came in for the primary complaint of bleeding from the penis with a decreased appetite and lethargy. This is a picture of Wesley laying in right lateral recumbency and hooked up to an IV line. On physical examination, the cat was 5% dehydrated. Its mucous membranes were white. Its capillary refill time could not be recorded. Its rectal temperature was very low at 96 degrees Fahrenheit. It had crusty ocular discharge in both eyes. Heart rate was 192 and a normal sinus rhythm. The pulses were weak. The cat was tachypnic at 42 breaths per minute, but was still purring. On abdominal palpation, the cat had splenomegaly. That's a key physical finding here. The bladder was normal. Despite the fact that it had a history of blood on its penis, its bladder was normal. It was considered thin. There was a bloody discharge at the tip of the penis, but there was no sand suggestive of a urethral obstruction. The cat did have severe fleas, but we didn't think that the fleas were severe enough to cause the white mucous membranes. So we were concerned about some sort of red blood cell destructive disease leading to splenomegaly. This is the urine from the cat. You can see that it's very brown. When looked at it closer, it was red, and so it was evidence of hemoglobin in the urine. When you did a dipstick on the urine, it had hemoproteins, bilirubin, and proteinuria. And remember, any amount of bilirubin in cat urine is abnormal. Cats do not normally secrete any bilirubin in their urine. So if you see that on a profile, you will know that there is something wrong with the bilirubin metabolism within that cat. Its hematocrit was low at 8.5%. Its mean cell volume of its red cells were enlarged again at 60 femtoliters. Remember, cats have a different mean cell volume than dogs. Normal in cat goes from about 35 to 48 or so. So 60 as an MCV is very large for cats. So evidence of macrocytosis. Look at the white blood cell count here. It's 69,000. That's huge. The 69,000 is comprised of 46,000 neutrophils, 4,000 bands, and lots of metamyelocytes. Again, you might be thinking this cat has an infection, but don't get fooled still. This cat could have a real high reticulocyte count, and the bone marrow could just be putting out more white cells as it tries to keep up with red cell destruction. Platelets were adequate. Fibrinogen was normal at 300. The plasma proteins were 8.2. You can see on this Icarus index there was intravascular hemolysis, and there were nucleated red blood cells in the peripheral blood. This is all very compatible with immune-mediated hemolytic anemia in this cat. Reticulocyte count, you can see here, is very high, 60% aggregate retics. Platelet counts were adequate. Hemobartonella felis was negative. It was autoagglutination positive. We did 1 drop of blood and 1 drop of saline, and it was positive. So this is diagnostic for immune-mediated hemolytic anemia. There's no reason to do other diagnostic tests on this cat. It should be treated for immune-mediated hemolytic anemia. The mechanism here is the same as the destruction in the dog. You should be aware that serocytes are only rarely recognized in the cats. Immune-mediated hemolytic anemia in cats is rarely idiopathic. Usually it's associated with Hemobartonella, FELV, or some sort of drug administration. So in this cat, our treatment plan was to give it a blood transfusion, place it on prednisone and Cytoxan, fluid support, external heat, and tetracyclines just in case it had an underlying Hemobartonella infection. This is the urine of the cat. 48 hours later, you can see that there is no more hemoglobinuria. And this is the cat. It responded dramatically to therapy. And this is immune-mediated hemolytic anemia. Now, immune-mediated thrombocytopenia follows the exact same plan as immune-mediated hemolytic anemia. In this case, when you do your hemogram, you're going to see platelet counts that are very low. Immune-mediated thrombocytopenia has platelet counts that are normally in the range of 7,000 to maybe 50,000. Normal platelet counts are 200,000 per microliter. And yeah, there's lots of different causes of immune-mediated thrombocytopenia besides immune-mediated. You could have DIC, you could have Ehrlichia infection, you could have underlying tumors, you could have some drug-induced problems, but with immune-mediated thrombocytopenia, you routinely see the lowest platelet counts of any disease process. And I guess I want to leave it there with thrombocytopenia. I would encourage you to read about it in some textbooks, but I don't want to spend another 15 or 20 minutes trying to get you through that. I have some other diseases that I want to get to. Remember, immune-mediated thrombocytopenia is a type 2 hypersensitivity, exactly like immune-mediated hemolytic anemia is. Antibodies are being bound to the surface of platelets. The diagnostic test that you would want to do would be a bone marrow analysis. And you would stick a needle in the bone marrow, pull out the bone marrow, evaluate it on a blood smear, and you'd expect to see large numbers of megakaryocytes within the bone marrow, indicative that the bone marrow is trying to make platelets, but they're being destroyed in the peripheral blood. Now, the clinical signs that you would see would be bleeding. Bleeding around the retina of the eye, and the sclera of the eye. You can see ecchymotic hemorrhages in the skin, in the neck, where you would shave to draw blood samples. Usually they respond dramatically to treatment, the same type of treatment again, corticosteroids, potentially immunosuppressives such as azathioprine or cyclophosphamide, and that would be the story for both dogs, cats, and horses on immune-mediated thrombocytopenia. Okay, I want to work you through type 3 hypersensitivities now, which again, as you know, are caused by antibodies. And the phenomenon that we're going to see is glomerular nephritis leading to the nephrotic syndrome. So the objectives of this portion of the talk is to give you some underlying physiology of glomerular function and to go through some etiology of glomerular injury, and then to discuss the nephrotic syndrome as it affects our veterinary patients. This is a photograph of the aorta, the renal arteries leading out to the kidneys, and then the yellow portion of the material is the ureters as they come down from the kidneys to the bladder. And if you look really closely at this blow-up, you can see a glomerular tuft. And the glomerular tuft has an afferent arteriole coming into it and an efferent arteriole going out of it. And this is a diagrammatic representation of the afferent arteriole as it comes into the glomerular tuft and the efferent arteriole as it exits on the other side of the glomerular tuft. And that glomerular tuft is the area where you get urine filtration into Bowman's capsule, Bowman's space, down the proximal tubule, then into the collecting ducts, and finally into the ureters and the bladder. And if you look at a diagrammatic representation then of the working unit inside that glomerular tuft, on the top of the slide you'll see the word plasma, and that would be the inside of the little capillary inside the glomerular tuft as blood is flowing through the glomerular tuft itself. You can see the representation of the capillary endothelium, and it is just next to the basement membrane, which has 3 layers to it. A clear layer, and then a white layer, and then another clear layer, and on the bottom then are the epithelial foot processes which make up the filtration slit for urine to pass through. And this is a scanning electron micrograph then of that exact same diagram that you saw. On the top is the plasma space, the epithelial cells with holes in between the epithelial cells, the 3 layers of the basement membrane, and then the podocytes, or the foot processes, on the bottom, and then in the white space below, that's where the urine would be being collected inside Bowman's capsule. And this is a scanning electron micrograph then, looking inside the capillary, inside the glomerular tuft. And you can see the little arrow there is actually pointing to the holes between the epithelial cells where the urine would flow into the basement membrane. And now this is on the opposite side, inside the Bowman space where urine would actually be forming. And you can see the podocytes that have created these finger-like projections on top of those capillaries. And so if you were to, poke your finger in through there, you'd be poking through a podocyte into the basement membrane, the 3 layers, and then out through one of the holes inside the epithelial cells on the other side. And this is the same type of view. This side on the bottom of the slide is the capillary lumen. And then you can see where it says CL, that stands for capillary lumen, the epithelial cells and the spaces between them, the 3 layers of the basement membrane zone, and then on top now the podocytes, and the arrow there is pointing to a little black dot, which is actually the filtration slit where urine passes through. So every time the artery pumps, blood pressure will go up inside that little capillary, the little glomerular tuft will expand, and urine will be forced through the epithelial hole, through the basement membrane, and then right out that little epithelial slit into the Bowman's space. And so if you were to look sort of at my wrist and my hands, with this being an afferent arteriole and this being an efferent arteriole, and then my fingers making up the capillaries, everything would pulse with every beat of the blood, and the little capillary membranes would jump as urine is being, pushed through, and the urine would go through the spaces into the collecting duct out here, and would then travel down the proximal tubule into the urinary system. And that's how the kidney kind of works to filtrate its blood. And this is another view. This is kind of hard for me to explain without being able to walk up to the slides and point to things as I'm showing it to you. But what you're looking at are the podocytes and the filtration slit now. This little arrow pointing at these black dots, that's the actual area between those podocytes where urine is formed. Okay, so this is now a diagrammatic representation of that process. At the bottom of the slide is the capillary lumen. The two light orange areas are epithelial cells, and normally these spaces are very small, and they're all negatively charged, so that proteins, negatively charged albumin, is unable to go through the basement membrane or past the podocytes into the urinary space. And so normally, when urine is formed, it doesn't have hardly any protein in it at all. Maybe 1+ protein when you do a dipstick analysis, but certainly not 3+ or 4+ protein in the urine. In between the glomerular tufts is another cell called the mesangial cell. This is actually a phagocytic cell, and it's responsible for cleaning up any debris that would get caught between the basement membranes and the podocytes. All right, so if you have immune complexes being formed where antibody is binding antigen, and these immune complexes are relatively small in size, being comprised of maybe 3 or 4 antibody molecules attached to 2 or 3 antigens, they are small enough to actually get into that basement membrane of the glomerular tuft. And now if you think about antigen and antibody being in that basement membrane, it's going to activate complement. And the complement proteins C3a and C5a are going to be formed at that site, and they are chemotactic. They will call into that epithelial area neutrophils and macrophages to actually phagocytize up that debris. And in immune complex disease, where you get antigen and antibody being deposited in that basement membrane zone of the kidney, you'll get lots of inflammation, and that will cause kidney damage or glomerular damage. And we call that glomerulonephritis or glomerulitis, inflammation of the glomeruli. And the fallout of this inflammation is it destroys the ability of that nice filtration slit to keep protein out. And as a result, proteins, albumins, will pass relatively freely through the urinary filtration area into the urine, and then you'll get lots of protein in the urine. And so the hallmark sign of glomerulitis would be proteinuria. And you would pick that up on a dipstick. And you should worry then about the possibility of immune complex disease in situations where you have a lot of protein in the urine. All right, now on this slide, the key point here is on the left hand on the y-axis is concentration of material in the blood or in the plasma. And on the x-axis, going horizontally, is time. And the top line is antigen. And at the beginning here, you have a lot of antigen in the bloodstream, but hardly any antibody at all. And you're not going to see any disease at that point because there isn't any immune complexes being formed. But in this zone where antibody and antigen get close to being in similar concentrations, you will start getting the deposit of antigen and antibody in the basement membrane, and you will then develop evidence of glomerulitis or inflammation. And it's usually in the zone of slight antigen excess. And so it's important that you know that when you have slightly more antigen than you have antibody, is when you're going to run into the formation of these immune complexes which are soluble. And remember, they will deposit anywhere within the vascular system that is present. And so you could get immune complexes being deposited outside the capillaries in your skin. You could get evidence of dermatitis. You could get evidence of arthritis. You could get evidence of uveitis, evidence of glomerulitis. These immune complexes don't just target into the kidney itself, but go into multiple places. And so immune complex disease is a phenomenon that will affect multiple organ systems. We're going to focus on the kidney and the glomeruli, but it can be occurring in other areas as well. Okay, this is just another example of antibodies going through and binding antigen in the basement membrane, activating complement, leading then to C5a and C3a, chemotaxis, inflammation, and then destruction. Okay, so histologically then, you would see basically three types of glomerulitis. Membranous glomerulitis, or glomerular nephritis, where the basement membrane zone is just thick. Okay, so it's swollen, it's no longer this normal size, and it's thicker than normal, and that's called membranous glomerulonephritis. Proliferative glomerulonephritis is when you have an increase in the numbers of mesangial cells and an increase in the numbers of inflammatory cells within the glomerular tuft. And then the last kind is a combination of both, where not only is the membrane, basement membrane thick, but it's also heavily infiltrated with inflammatory cells. Okay, and then once you get to that phase, then you lose those negative charges that were present within the glomerular basement membrane, and proteins then become much more freely passable right through the epithelial cells or endothelial cells of the blood vessel, through the basement membrane, through the glomerular tuft, podocytes, and then into the urine stream. If you were to do immunofluorescence then on a glomerular tuft using antibody against canine or feline or equine or ovine or bovine immunoglobulin, you would see it being deposited throughout that glomerulus. And so this is fluorescent antibody, indirect fluorescent microscopy, indicative of underlying immune complex disease in this kidney. So the question you would have then is, well, what could possibly be causing the antigen source to create glomerulonephritis in my patient? And so you'd be looking for some sort of underlying chronic disease. One of those diseases would be heartworm disease in the dog, where you would have constant exposure to adult male and female antigens as well as microfilaria. You could have an underlying tumor. In this case, this dog has lymphoma, and its tumor cells are constantly releasing antigen. Antibody is being formed against these neoplastic antigens and are being deposited in the kidney, resulting in severe proteinuria. You could have an underlying systemic lupus erythematosus, and this animal is exhibiting skin changes associated with SLE, and SLE is the prime disease that we use to talk about immune complex disease. And we're going to now work through SLE as an underlying condition. But remember, it could be immune complexes could be associated with any underlying chronic antigen exposure. In SLE, it happens to be nuclear or cytoplasmic antigens, and it's an autoimmune disease. But it could be heartworms, it could be fungal antigens, it could be viral antigens, it could be other things that an animal could be exposed to. All right, and so one of the key signs will be edema formation when you have immune complex disease because of all the inflammation that's occurring within the vascular system. So this is a urinalysis, and this animal has yellow, very clear urine. The specific gravity is 1.028. pH of the urine is normal, but the protein in the urine is 4+. There's no evidence of blood in the urine, no bilirubin, no urobilinogen, glucose is negative, ketones are negative, and if you look at the sediment, there's no sediment. There are hardly any white cells, hardly any red cells, there's no cast, there's no bacteria, the urine's clear, crystal clear, but yet it's got 4+ protein, and that right there would be the classic sign of an underlying glomerulitis. And you should feel confident as a clinician saying, this patient has glomerulitis. And now it's your responsibility to determine, well, what's causing that underlying glomerulitis in that patient? Where is the antigen-antibody complexes that is doing it, or what is the underlying pathology in that kidney that's causing all this loss of protein? And that's going to be impossible for you to read, so we're going to just skip by that. Okay. The other thing that I want you to be aware of, when you have such massive protein loss in the urine, is you're also losing other proteins in the body. And it will typically lead to these three phenomenon when you have high levels of protein loss. Number one, the patient will have hyperfibrinogenemia. And this is the protein that's involved with causing coagulation. You'll also have high factor VIII levels in the blood, and you'll have a loss of antithrombin 3, which is a very small molecular weight protein. Those three factors, high levels of fibrinogen, high levels of factor VIII, and low levels of antithrombin 3, set a patient up to undergo massive intravascular coagulation and thrombosis. You need to be aware of that. So whenever you have 4+ proteinuria or high levels of proteinuria, be aware that that patient may be at risk for underlying hypercoagulation. This is Mr. T. He presented as a patient with evidence of proteinuria, and he was depressed, very hydrated, membranes were pink, refill time was 2 seconds, temperature was normal at 101, bilateral entropion, mucoid debris, and medial canthi of his eyes, which really wasn't significant for him based on his breed. Heart rate was 132, normal sinus rhythm. There was a slight murmur, no pulse deficits. He had slight tachypnea at 42 breaths per minute, but his lungs were clear. He also had organomegaly, most likely his liver, in his cranial abdomen, and had significant ascites. His body condition was considered thin. He was a male. Both testicles were present, and he had mild prostatomegaly and dry skin. The things that concerned me the most were his ascites and his tachypnea and his rapid heart rate. On his hemogram, he had a slightly low hematocrit at 31%. His MCV and HC were normal. White cell counts were slightly elevated at 20,000, comprised mostly of a mature neutrophilia. Platelets were adequate. Here's the key. The fibrinogen level in this patient was dramatically elevated at 900 milligrams per deciliter. That's phenomenally high. And you would have to worry about hypercoagulation when that fibrinogen is that high. On his chemistry profile, his liver enzymes were realistically within normal limits. His calcium level was a little on the low side at 7.6, but when you look over at his albumin, that's another real key. It's real low at 0.9. So having a low albumin like that, you'd have to ask the question, where is the albumin going? Why doesn't he have normal levels of albumin? And you should be thinking it's either a loss of albumin or a lack of production. And very rarely is it ever a lack of production. It's usually a loss. And you usually lose it like that through the kidney. And you can see his kidney values are elevated. His creatinine is elevated. His BUN is elevated. And his cholesterol is actually high. He's got a metabolic acidosis with a total CO2 of 12. And this was his urinalysis. Medium yellow, slightly cloudy, low specific gravity at 10-11 grams per mil. Protein is 4+. That's abnormal. And that would be, the thing that you would hang your hat on. And that would explain his low albumin because he's losing it in his urine. And you've already got evidence that he's got very high levels of fibrinogen, and you should be scared to death at this point because the patient could have very high levels of factor VIII and very low levels of antithrombin 3, and it could be a time bomb just waiting to go into hypercoagulation. At this point, I called the owners and recommended that we put Mr. T to sleep. I didn't have any good treatment options for him that I was able to identify, and although I got in an argument with my student felt like this patient didn't need to be put to sleep. Before I could get to the pharmacy and get the euthanasia solution and come back and put Mr. T to sleep, he actually died spontaneously due to massive thromboembolisms. And when we did a necropsy on Mr. T, he had the most severe pulmonary thromboembolic disease that I've actually seen. So you should be aware of this syndrome. When you lose lots of protein in the urine, you run the risk of losing antithrombin 3 with elevated levels in the blood of fibrinogen and factor VIII, which sets the patient up for possible thromboembolic complications. All right, that's just another picture of Mr. T just before he actually passed away. Okay, so again, with these immune complexes, it not only affects the kidney, but other peripheral areas as well. Patients will present with edema of their extremities. They'll have low levels of albumin, and the differential diagnoses for low albumin levels would be reduced hepatic synthesis, massive GI loss, massive renal loss, or lack of dietary intake. And in the absence here of diarrhea in Mr. T and a history of having a fairly normal appetite up to a couple of weeks ago, it wouldn't be due to dietary restriction. The only thing it could be would be loss of proteins through the kidney. The diagnostic considerations at this time then in Mr. T would be to look for a anti-nuclear antibody test to diagnose SLE. Look for occult microfilaria, do thoracic and abdominal rads trying to rule out pyometra, abscesses, or neoplasias, which could all result in chronic antigen exposure. Treatment. Specific treatment is not available. Treatment plan for these patients would be corticosteroids or immunosuppressive agents such as azathioprine or cyclophosphamide. All right. Taffy, 6-year-old female spayed mixed breed dog. Primary complaint, decreased appetite, listlessness. Duration, 2 months of onset, and it's getting progressively worse. This is a picture of Taffy. Physical exam, she was hydrated, pink membranes, refill time 1 second, rectal temperature 100.3, maybe a little on the low side. Slightly waxy otitis in both ears, moderate dental disease, she had bad breath. Heart rate was 108, it's a sinus arrhythmia, a 3 out of 6 holosystolic murmur. She was normal respiration rate, was considered eupnic. Abdomen, there was nothing significant. Musculoskeletal, she had medial luxating patellas. Female spayed, no mammary gland tumors, no vaginal discharge. She had a slightly enlarged right submandibular lymph node. Her skin was fine. This was her hemogram. You can see that she's slightly anemic with a PCV or hematocrit of 26.5%. Her mean cell volume is low at 58 femtoliters, indicating a microcytic, and she's also hypochromic. Her MCHC is low at 30. So she's microcytic hypochromic, suggestive of a blood loss anemia. Her white cell count was on the low side at 5,200. Platelets are normal. The fibrinogen level is normal. And the abnormal finding here is her total proteins of 13.2. Tremendously high total proteins. On her biochemistry profile, her liver enzymes and electrolytes are normal, except her calcium level is high at 14.1. Her creatinine and BUN are high, indicating she has some underlying renal insults. Her total protein on here you can see is elevated at 14.7, and it's comprised of a 1.8 albumin and a 12.9 globulin. This is tremendously high total proteins, and you should be now considering possible underlying diseases associated with hyperglobulinemia. Urinalysis, specific gravity was 1018. It was light yellow and clear. And she had 3+ protein in her urine, which is getting on the high side. 4+, and you would definitely say it's abnormal. 3+, it's abnormal as well, but not as severe. And her sediment, she had a few red cells, but really within normal limits. This is a serum electrophoretic profile of Kathy's serum. And you can see that her albumin level was low here at 0.7, so somewhere around 1 albumin, and her globulin level very high and very tall, indicative of what's called a monoclonal gammopathy. This is a phenomenon caused by plasma cells, or B cells, which secrete only one type of antibody molecule. And this is indicative of an underlying neoplastic disease called multiple myeloma, again caused by a cancer of B cells secreting one type of immunoglobulin. And so this would be comprised of probably an IgG, multiple myeloma. And remember, when we talked about IgG molecules or immunoglobulins, they had 2 heavy chains, and they had 2 light chains that sat on the outside of the heavy chains. And each heavy chain was 50,000 molecular weight, and the light chains that sat on the outside were 25,000. Very frequently, when you get high levels of these monoclonal gammopathies in the blood, you will get excessive secretion of these light chains. And 2 light chains together will be secreted from the tumor cells. And those 2 light chains, when bound together, would be 25 and 25, so only 50,000 molecular weight. Again, remember, that's smaller than albumin. Albumin's only 67,000 molecular weight. And so these light chains actually get through the glomeruli of the kidney relatively easy and cause inflammation and complex disease. And a lot of times that's why you'll see glomerular nephritis with multiple myeloma is the result of these light chains being deposited in the kidney and then being excreted out into the urine. Okay, monoclonal gammopathy then is different than what is shown here, which is polyclonal gammopathy associated with an FIP infection in a cat. And on the left-hand side of this graph, you can see the albumin, and on the right side, you can see alpha, beta-1, beta-2, and gamma globulins. And there isn't any tall spike in the gamma globulin region like we saw with the multiple myeloma. And if I back up one slide, you'll be able to see that. Okay, the albumin here on the left being relatively low, and you can see how tall and how much protein is in that gamma region, versus this polyclonal gammopathy where it's not nearly as tall as the albumin and it's more spread out in the electrophoretic area covering alpha, beta, and gamma regions. When you look in the urine, then what you're actually looking for is light chains. And we do what's called a Bench-Jones protein test. And a Bench-Jones protein test is looking for immunoglobulin light chains in the urine. It's a heat precipitation test. The urine is adjusted to a pH of 5, and then you heat the urine. And between 50 to 60 degrees centigrade, a precipitate will form. As the temperature in that test tube gets up to 90 to 100, the precipitate will go away, and then as it cools back to 50 or 60 again, the precipitate will form, and that would be diagnostic of light chains in the urine, and one of the criteria then to diagnose multiple myeloma in your patient. And this is a test tube showing you that flocculated material at the bottom of the tube, indicative of the proteins from light chains. So the specific test here for Taffy was a Bench-Jones test, which was positive. We did a PT and a PTT, which is a coagulogram test. And sure enough, those values were elevated, and her platelet function was decreased. And remember, she had sort of a microcytic hypochromic anemia with a PCV of 26.5. The reason it's low is because she's actually losing blood through her GI tract associated with this multiple myeloma. So she has an underlying blood loss anemia. You should only do a bleeding time when you have a normal platelet count. If you have a patient who has immune-mediated thrombocytopenia and a low platelet count already, there'd be no reason to do a bleeding time on that patient because you already know it's bleeding like crazy. Because it's got blood under its skin, it's got blood in its eye, it's got blood in its retina, and so you would never do a bleeding time there. But in TAFI, where you suspect that she may be bleeding, but you can't see any evidence of it, and her platelet count was normal at 277,000, in her, you would want to do a bleeding time. And so you'd take a scalpel and make a small puncture wound in the mucosal surface under the lip and document a bleeding time in TAFI. And in her case, it was normal. It was abnormal. It was prolonged. And the reason it is prolonged is because of all the proteins in her bloodstream binding to the platelets and not allowing the platelets to undergo their normal function. This is a bone marrow aspirate from TAFI, and you can see here that she's got lots and lots of plasma cells in her bone marrow. Each of these cells has a nucleus that's pushed off to one side, and then the cytoplasm takes up the rest of the space on the opposite side of the nucleus. The nucleus has these characteristic cartwheel kind of shapes to it where you can see a fragmentation of the nucleus. And all that light staining area in those plasma cells is all antibody, all being released out to the bloodstream, causing TAFI to have such high levels of immunoglobulin in her blood. Some diagnostic criteria for multiple myeloma would be osteolytic lesions of bones. And in this case, there's a bump on this animal's shoulder. And if you did a radiograph, you can see she's got some lytic changes associated with the scapula in the dorsal region of her scapula. And if you did a fine needle aspirate of that area, you would find it infiltrated with plasma cells. And this patient also had multiple myeloma. The treatment for this disease is melphalan, which is a antineoplastic drug. And the active part of the molecule is on the right-hand side where the R group has CH2CH2 chlorine. And it's a bifunctional alkylating agent, binds to DNA, cross-links DNA, and causes tumor cell death because the cells are unable to replicate and produce normal messenger RNA. So the treatment for TAFI would be to reduce the neoplastic plasma cells with melphalan and prednisone. If that didn't work, we would go with a more aggressive approach, combining vincristine with the treatment plan, and we would end up doing neutrophil counts or CBC counts on her once a week for the first month and then once a month thereafter to make sure her white cells stay within the normal limits. If the patient has hypercalcemia, you need to treat for that. The number one rule first is to hydrate the patient, make sure that it's not dehydrated, and then to administer Lasix or furosemide. If that fails to reduce the calcium level, dexamethasone would then be used, and if that then fails, you would add salmon calcitonin to the treatment regimen. This is Gypsy. Gypsy presented because of abnormal mentation. And on retinal exam, the retinal vessels were very tortuous under direct ophthalmoscopy. And Gypsy ended up having hyperviscosity syndrome secondary to multiple myeloma and high levels of protein in her bloodstream. And so this would be another feature of multiple myeloma that you would check. Osteolytic bone lesions, plasma cells in the bone marrow, hyperviscosity syndrome, Bence-Jones proteins in the urine. Okay, Sarah, 4-year-old female spayed golden retriever, primary complaints, lethargy, decreased exercise tolerance, decreased appetite. It's a picture of Sarah. Hemogram. She's slightly anemic with a 30% hematocrit. It's normocytic, normochromic. White cell count is on the normal side at 9,000. But look at her platelets. Her platelets are low at 85,000. Now, that's not as low as you would see with immune-mediated thrombocytopenia. You'd expect those platelet counts to maybe be below 50,000. But 85,000 is low. There's something going on with Sarah, and she's also got a slight anemia to accompany this disease process. Her biochemistry profile shows normal liver enzymes, normal sodium, potassium, and chloride. Her calcium is normal. Creatinine and BUN are normal. Glucose, total CO2, and bilirubin are fine. But look at her protein now. It's high again. It's 11.2, characterized by a 1.5 albumin, which is low, and an elevated globulin. So the diagnostic test that you're going to do next would be a serum electrophoresis. You're trying to determine whether this is a monoclonal or a polyclonal gammopathy. All right, so we didn't do that yet. What we did do is look at a urine specimen, and you can see that the urine-specific gravity is pretty good at 1031. It doesn't have much protein in it, only trace. And it doesn't have much in the sediment either. So urinalysis-wise, it doesn't look like she's got much going on. All right, here's her serum electrophoresis. You can see that her albumin level has got a nice peak to it. And on the right-hand side, she's got kind of a polyclonal response. That's multiple parts of her profile are elevated, suggesting that she's got some sort of chronic antigenic exposure. So you'd have to be thinking now, in Sarah's case, what disease could she possibly have that would be causing her to be listless, anorectic, kind of lethargic, going on for a month, causing kind of a low red blood cell count, low platelet count, and lots of proteins from some sort of chronic antigenic stimulation. And you should be, beating your mind around saying, okay, could this be a tumor? I don't know. I don't think so. That guy doesn't quite fit. Could it be an infection? If it was, what kind of an infection? And so we did a bone marrow on Sarah to look inside to see what her platelet, her megakaryocytes were doing and what her cells were doing. And you can see that she's got lots of plasma cells here. And I'd hope that you could make them out now. They're the cells that the nucleus is kind of pushed off to one side. The cytoplasm is kind of blue, but it's got these light halo areas in it that are the antibody molecules that are being formed. And if you look kind of in the center of the slide, you can see maybe 1, 2, 3 as they go from the center down a little bit to the left-hand side, plasma cells right there in a row. And so whatever disease this is, it's making lots of plasma cells in the bone marrow and causing a polyclonal response. Well, it turns out that Sarah had an Ehrlichia infection. Very treatable with tetracyclines. Her Ehrlichia titer was greater than 1 to 2,560. It's quite common for Ehrlichia-infected dogs to have a mild anemia, a thrombocytopenia, evidence of a progressive kind of infectious disease course, and in some cases of Ehrlichia, you can actually see a monoclonal gammopathy. So you should be aware that an Ehrlichia titer is something that you would always want to run in a patient that was exhibiting a gammopathy. Okay, so this kind of goes through a little bit of Ehrlichia, non-regenerative anemia, thrombocytopenia, some sort of leukopenia in some cases, and normally a non-regenerative kind of bone marrow response. Treatment is with tetracycline or doxycycline. Okay, and this is a little plasma cell tumor inside, underneath the skin of a dog's elbow. You should recognize that although multiple myelomas are caused by plasma cells in the bone marrow that secrete lots and lots of antibody, you can have plasmacytomas, which is a tumor of plasma cells in the skin or underneath the skin that just presents as a lump and does not produce antibodies. And so with this particular patient and that lymph node enlargement behind the elbow, this plasma cell tumor, I wouldn't expect that to have a lot of antibodies in the bloodstream because typically they don't secrete antibody in that location. When it's in the bone marrow, they will release lots of antibodies, but a plasmacytoma in the skin or in the foot pad of an animal will stay dormant and will not secrete a lot of antibodies. Okay, thanks for staying with me here, you guys. We're going to work for maybe about another 15 to 20 minutes, and then we're going to wrap this up. I want to work you through some inflammatory arthritises associated with underlying immune-mediated diseases. When you have an arthritis, really you need to be thinking about either infectious arthritis, such as bacteria, mycoplasma, fungal, viral, or non-infectious arthritis, which could be immunological in nature. And these immunological arthritises are broken up into erosive diseases, such as rheumatoid arthritis, or non-erosive disease, such as systemic lupus or drug-induced exposure. This is a little patient I saw. Her name was Muffin. And on presentation, Muffin was quiet, alert, responsive, well-hydrated. Her mucous membranes were pink. Refill was a second. Her rectal temperature was a little bit elevated at 103.6. Eyes, ears, nose, and throat showed no significant findings except some mild iris atrophy on her left side. Heart rate was 130, normal sinus rhythm, no murmur, no deficit. She was euthymic at 20 breaths per minute. Abdomen was normal. Left carpus, though, had a lot of crepitus in it and a lot of swelling associated with it, and she was very painful on it. The right carpus also was abnormal, but the left was much worse than the right. She was a female spade, no abnormalities detected in her urogenital system. Integument was normal, as were her peripheral lymph nodes. So the main findings we were going on here was a fever and her joint pain. Her hematocrit showed a normal red cell count at 42%, normocytic, normochromic. White cells, 10,700, nothing to write home about there. Platelets were adequate, fibrinogen slightly elevated at 400 milligrams per deciliter. Her proteins were a little bit on the high side at 8.3, but not as dramatic as those that we saw with multiple myeloma or Ehrlichia. This was a radiograph of her right carpus, and it showed some joint swelling, but no erosive disease, no underlying abnormalities except for evidence of mild collapse of the joint space and swelling. Now, the diagnostic test of choice then for Muffin was to do a needle aspirate of her joint. Now, this is not her leg. This is a little boxer dog that has Demodex. And you certainly wouldn't want to take a needle and stick it through that inflamed skin and likely multiple infected skin spots and then into that joint. I would not do a joint tap on a dog that presented with a skin condition like this. But if the patient has normal skin, there should be no worries for you to clip up the hair, prep the joint space with betadine and alcohol, and do a needle aspirate of that joint. This is not a scary thing for you to do. You should be able to do it well, and you need that fluid to determine what's going on inside of Muffin's joint. And you're trying to figure out now, is this an infectious process that's leading to swelling and fever and joint collapse, or is it a sterile process that's associated with an immunological disease? So you need to do a joint tap. This was the joint tap then from Muffin. You can see there are lots of neutrophils there, and then there are some macrophages. There is no evidence of bacteria that you can see in this joint fluid. This is indicative of what an immune-mediated joint aspirate would look like. The readout on it was left stifle. We even aspirated the stifle on this patient. The cell count was about 25,000, composed of 86% neutrophils, lymphocytes 9%, macrophages 5%. Comments: the sample was highly cellular, contains an eosinophilic stippled background consistent with a fair amount of mucin. Neutrophils were non-degenerative or non-toxic. There were some mononuclear cells which appear reactive, plasmacytoid in origin. Left carpus and right stifle had similar reports. And this is all 100% consistent with a sterile immune-mediated arthritis. And the question that you now have to determine is, well, what kind of underlying sterile immune-mediated arthritis is this? Is it rheumatoid arthritis? Is it systemic lupus erythematosus? Is it a drug-induced arthritis? Did I miss something in the history? And you'll need to work through that process. This next table here gives you some synovial fluid cytology and allows you to kind of characterize cell counts with underlying conditions. A normal joint should have roughly 250 to 3,000 cells per microliter in the joint, and those cells are usually mononuclear in character. A degenerative joint like degenerative arthritis will have a little more cells, but not very many, 1,000 to 5,000 cells. Rheumatoid arthritis, you'll now start seeing more cells, some 8,000 to 38,000. And the differential on those cells will be from 20% mononuclears to maybe 80% mononuclears. And so if you are up around the neighborhood of a 38,000 white cell count in the joint fluid, you probably have 20% mononuclears, and the majority of them being then polymorphonuclear, or those neutrophils on the right-hand side. Non-erosive arthritis would be like your SLE or your immune-mediated arthritis, and you can see the synovial counts range from 4,000 to almost 400,000, really high white cell counts. And when you get up with the really high white cell counts, again, the majority of those are going to be neutrophils, or those polymorphonuclear neutrophils. Septic arthritis will also have high white cell counts. You can see that down at the bottom, ranging up to near 300,000. And again, those will be neutrophils, but you should be able to see bacteria in the joint if it's due to septic arthritis. So the key is to know what kind of cell count you're going to expect, and then to be able to look under the microscope and see what kind of cells they are. Diagnostic criteria for rheumatoid arthritis: stiffness after rest, joint tenderness, swelling of at least one other joint, symmetrical joint swelling, erosive changes on your radiograph. You'd want to submit serum from a rheumatoid factor test to see if it is rheumatoid factor positive, and then you'd look at your synovial fluid. This is a histopathology of a joint with rheumatoid arthritis, and you can see the heavy infiltration of inflammatory cells underneath the joint capsule there. And if you take another look at it, you can see again their kind of villus formation here with a heavy infiltrate of inflammatory cells. And if you look at this line diagram, on the bottom is kind of the normal joint morphology, where you have the bone marrow, then you have a white layer of subchondral bone, and then you have this stipple layer of what they would trying to demonstrate here is normal articular cartilage. And then your joint space. Now on the top there should be another bone that looks identical to that one, but what you see on the top is a joint that would be indicative of rheumatoid arthritis. And you can see that the articular cartilage has been eroded away with these diagonal lines called pannus, or inflammatory infiltrate. And you can see that the pannus on the top left has worked its way all the way through the articular joint, articular cartilage, through the subchondral bone, even into the bone marrow itself. And it's caused this punched out radiographic lesion that you would see on radiograph, indicative of an erosive, destructive inflammation. This next slide gives you a pathological specimen that shows this pannus formation. On the lower right-hand side, you can see the smooth surface of the normal cartilage present, but then right next to it, you get all this villus formation, and you can see how it's invaded right through the surface of the articular cartilage, and is probably invading the subchondral bone and underlying tissues underneath. And it just is a very destructive process, and you would be able to see that radiographically. The pathogenesis of rheumatoid arthritis, the antigen here is dog IgG, or it's IgG in any species, horse or man or cat, it makes no difference. The antibody then is IgM or IgA and even IgG against that antigen IgG. It's known as rheumatoid factor, and it binds to the Fc region of the IgG. So in this case, IgG is the antigen, and the antibodies are binding by the FAB region right to the tail of the IgG as an antigen. It causes erosive arthritis and pannus formation. Treatment for this underlying disease would be corticosteroids and, again, immunosuppressive agents. Non-steroidal anti-inflammatories such as aspirin can also be used. All right. This last patient, his name is Shadow, and Shadow has SLE, or systemic lupus erythematosus. The hematocrit on Shadow has 34% PCV, normocytic, normochromic. White cell count is elevated at 38,000. The fibrinogen you can see is high, indicative of an underlying inflammatory condition. And the total proteins are a little bit on the high side as well at 8.4. Urinalysis is 3+ proteinuria and lots of white cells in this animal's urine. And this would be suggestive of an underlying glomerular nephritis. Radiographs, non-erosive arthritis in this case. We did a joint tap and put the fluid in a little EDTA tube. And when we smeared it out, you can see that there were lots of neutrophils present. High cell numbers, lots of neutrophils, no evidence of bacteria. Contrast this slide here to this next one, which shows an animal with septic arthritis. You can see the neutrophils here look more toxic, and you can see the little bacteria actually in the cytoplasm of those neutrophils. The arthrocentesis on shadow was consistent with chronic immune-mediated disease, no evidence of bacterial growth on culture, and we ended up diagnosing systemic lupus erythematosus in that patient. And we did that with what's called an anti-nuclear antibody test. That slide shows normal hepatocytes being stained with antibodies from the patient that bind to nuclear material, indicative of immune complexes that are forming against nuclear antigens. This last slide, and I'm going to stop here with this slide, gives you the diagnostic criteria for canine SLE. It's broken up into major signs and minor signs. The major signs would be a polyarthritis, a glomerular nephritis. You would diagnose that by seeing protein in the urine. A bullous dermatosis, where there are skin lesions present, characterized by bulla formation in the mucous membranes. You could have immune-mediated hemolytic anemia present, immune-mediated thrombocytopenia, or immune-mediated leukopenia, or polymyositis. All of those would be consistent with major signs associated with SLE. Minor signs would be fever, pleuritis, oral ulcers, depression or seizures, myocarditis, pericarditis, or lymphadenopathy. Serology would be a positive ANA or anti-nuclear antibody test or a positive lupus erythematosus cell test. To make a diagnosis of classic SLEs, all you need is 2 major signs and a positive serology. So with shadow, we had evidence of myositis. You could see the temporalis muscles were severely atrophied in her, and we had proteinuria present, as well as evidence of polyarthritis. And we did a positive serology test. She had a positive ANA, and so she would be diagnosed with an underlying systemic lupus erythematosus. All right, I want to remind you that we're going to get together via a conference call later on. I would encourage you all to come so that you can ask questions, and I'd hope to be able to clarify some of these underlying conditions that we've talked about. I would encourage you to look at Ettinger's Textbook of Internal Medicine and to read the chapters on immunological diseases. I think that'll probably work you through these concepts in small animal medicine the best. And I look forward to seeing you all. On behalf of the University of Florida College of Veterinary Medicine, thank you for your attention. And although it's been 2 hours, I hope you've learned a lot. I look forward to talking to you in the future. Thanks.